Okay, well, it's a huge pleasure to have you all here today, and a lot more people online as well. I have the real honor of introducing our speaker today, one of the arguably the world's leading cardiologists and epidemiologists, who's made a massive contribution to cardiovascular research, especially within India. He's the Vice President of the Public Health Foundation of India and holds honorary professorships at McMaster University and the London School of Hygiene and Tropical Medicine. So today's talk is going to be about the innovations to address the epidemic of cardiovascular disease. So I'm sure we're all going to learn a huge amount, and it's a real pleasure to have you here today.
Yeah. Okay. So, good afternoon, everyone. Thank you for inviting me to give this talk, and it's a pleasure being here at Glasgow. This is my third or fourth visit. Every time I come, I learn something new, see something new, and enjoy some new whiskies here. So it's always fun to be here. So we are technologically challenged here. So you can see two of us here. We're going to simultaneously work, one for the Zoom and one for the room, and hope it works. So in the next 45-50 minutes, I'm going to talk about some of the innovations that are required to address the epidemic of cardiovascular diseases across the world. Okay, this doesn't move forward. Yeah, okay. Being in UK, I couldn't but resist using a quote from Charles Dickens, who wrote The Tale of Two Cities some 200 years back. And the book starts with this line: it's the best of times and it's the worst of times. So when I think of cardiovascular disease, I can say it's the best of times and it's the worst of times, because there has been tremendous achievement both at population and individual levels in terms of cardiovascular disease prevention and management. There's been a population level decline of cardiovascular mortality of more than 50% within one generation in several high income countries. There's been a decline in acute myocardial infarction mortality from 30% to 4%. When I think of the 60s and 70s, people with a heart attack used to be admitted to hospitals. They used to be kept in a small room and nothing was done, waiting for them to get better and be discharged in a month's time or so. And mortality at that time was 30%. Tremendous advances in prevention as well as management has resulted in substantial decline in people who survive myocardial infarction. There's been a substantial decline in cardiovascular risk factors, but the big but is because in several low-income, low-middle-income countries, the prevention policies are not given priority. The health systems are in a disarray. Access for treatment is poor. Awareness is poor. There's huge disparities in care. Even within a country like UK, there are disparities in care, but across countries, there are huge disparities in care. There are simple and essential drugs are not available. For example, following a heart attack, you require 4 simple drugs, which would cost you less than, say, 2 or 3 pence. And those drugs are not available to several people across the world. And there are gaps between best practices and actual delivery. So if you have to address this epidemic of cardiovascular disease, what are the innovations that are needed? I think we require to look at a paradigm shift in our thinking. A few years back, we were talking about cardiovascular disease prevention, which meant that we were focused on adding life to years. We wanted to prolong life by reducing or decreasing cardiovascular deaths. But when you move away from that thinking to cardiovascular health, you are adding life to years. Earlier, you were adding years to life. Now you are adding life to years. That means people will be living longer, but living healthier. The second innovation that needs to be thought of is interventions across the life course. It's not that you need to wait for people to develop the disease and treat them, but you need prevention strategies even at the time of, even before the child is born and till the person dies, you require prevention strategies. We need to understand mechanisms of cardiovascular disease in individual country and cultural context. Something that is done in UK or US may not be replicable within India or in China or Southeast Asia. Just to give you an example, the treatment of hypertension across the world is based on old trials conducted in the UK and the US. And one of the things for 30 years, we said beta blockers should be the treatment, first line of treatment for hypertension. Now, when you think of a South Asian phenotype, a person originating from India, Pakistan, Bangladesh, or Sri Lanka, how would you describe that phenotype? How would you describe that person? Has a very high risk for diabetes, has very high levels of triglycerides, has low HDL cholesterol, has low physical activity, right? And what does the beta blocker do? The beta blocker increases the risk for diabetes, increases triglyceride levels, decreases HDL cholesterol levels, and makes the person lethargic, so that there's no less physical activity. So we were using those drugs. So I think you really require to look at local context in terms of research. Then we need to look at the health systems, and we need to redesign based on the economic condition of the country, but give the best possible care. So you require a redesign of the primary care to strengthen primary care. Then we need to evaluate task shifting and task sharing, given the shortages of doctors across the world. Then we require to simplify digital health solutions. And we need to put people and patients at the center of all this. They are at the center of all the programs that we need to think of. So I'm going to give some examples of all of these in the next few minutes. So when you think of cardiovascular diseases and you ask people what are the causes of cardiovascular disease, they'll tell you that it's a globalization and urbanization which has led to lifestyle changes, which has resulted in three major changes. That is diet, unhealthy diet, low levels of physical activity, increased use of tobacco. And to this mix, the WHO has added air pollution and alcohol, leading to several cardiovascular risk factors, ultimately resulting in cardiovascular mortality and morbidity. But also it is predicated, once you develop the disease, the survival is predicated on the availability to good quality care. So these are the things which people talk about. But in addition, people will also talk about genetics, fetal programming, which I'm going to talk about a little bit later, conditioning factors such as poverty, education, stress, and the life course socioeconomic status. But also recently, we are talking a lot about air pollution, climate change, lead poisoning, and several others. So these are some of the emerging themes in cardiovascular disease. So it is said, as someone said, cardiovascular disease starts in the womb and ends in the tomb. So you require prevention across the lifespan. But for designing interventions to reduce cardiovascular disease, we need to understand the underlying mechanisms in each of the ethnicities, in each of the countries, in each of the local contexts, because the context differs. So let's take two examples. There are several examples that are available, several areas of work that we've done. I'm just going to give you two examples. So first is, do we know the cause of diabetes in Indians and what can we do about it? Second is, what is the role of air pollution, hypertension, and chronic disease in India? In fact, the high risk for diabetes was mentioned in an editorial in Lancet in 1907, where they said what gout is to the nobility of England, diabetes is to the aristocracy of India. So both the nobility and the aristocracy in India have gone, but diabetes has remained. So if you look at the causes of diabetes, people will say it's lifestyle change, again, globalization and urbanization in genetically predisposed individuals, leads to increased overweight and obesity, ultimately resulting in increased insulin production. There comes a time when there is resistance to that insulin action, and the pancreas is unable to cope up with the excess load of glucose and inadequate insulin action. So the people develop diabetes and impaired glucose tolerance. This is the hypothesis. And some genes have been identified, but not the contribution may be 80% environmental, 20-25% genes. But is this the cause? So let's look at an ecological comparison. This was these are data from the WHO, which came in 2012. They said overweight and obesity in the US, they defined overweight as BMI greater than 25 and obesity as greater than 30. The proportion of people having either overweight or obesity was close to 2/3 of the US population. In China at the time, it was around 30%. In India at that time, it was 13%, and in Japan, around 29%. But look at the prevalence of diabetes. It's remarkably similar in US, in China, and in India. Why is that the case? If we go back to the popular theory that it is the overweight and obesity which is fueling the burden of diabetes across the country, how do we explain this lack of difference between these three countries? So one might say that ecological comparisons are not the best way to compare. You have to compare within a local population. There was a study that was reported in 2010 from my colleagues in Emory, Dr. Venkat Narayan and his PhD student, who looked at the differences in the prevalence of diabetes amongst people and the age of onset of diabetes amongst the people of different ethnicities within the United States. And as you can see, they related it to BMI here. And you can see the Indian subcontinent, which are marked with red. Even at the lowest levels of BMI, they had the highest prevalence of diabetes as compared to other ethnicities, suggesting that there is something which is different. So the second thing is there is a concept called the thin fat newborn. This is a study which was conducted in India and in UK by Dr. Yajnik and Dr. Yudkin in London. The Indian newborn was thinner, but had more fat than the UK newborn. So is there a story in that? So they did a comparison. They actually published this and called this the YY paradox, because if you look at Yudkin and Yajnik, they're very healthy individuals, health conscious individuals, they exercise. But despite that, you look at the proportion of body fat, the BMI is similar remarkably. I don't know how it happened. BMI was 22.3, but Yajnik had 21% body fat and Yudkin had 9% body fat. So is there an explanation for that? What is the reason why there is a higher body fat? There has been a intense research across the world for this. So one of the several reasons have been attributed to that, but ultimately this could be fueling the increased risk of diabetes, particularly fat that is deposited around the abdominal area, around the omental area, making the fat cells inflammatory, undergoing some paracrine effects from the liver and other organs, and increasing the risk for diabetes. But I think one of the things that has not been studied very well, that has not been reported, I shouldn't be talking about that in UK because it emerged from UK actually, this thing about poor maternal and early child nutrition. So this goes by the name Barker of Forstall or Barker's hypothesis. Being in Scotland, you may be more closer to the Norwegians rather than the British. So you can use whichever hypothesis you want, whether Barker or Forstall. So they said a stimulus or insult at a sensitive or critical period of development has lasting or lifelong significance on the structure, on the physiology, on the metabolism of organs. If there is undernutrition during the fetal life, the kidney may not be very well developed. The glomerulus in the kidney may be lower. The islet cell in the pancreas may be lower. There may be alterations in the physiology because of the stress hormones that are secreted during the fetal life. And there may be alterations in the metabolism because the fetus may become very efficient in storing fat. And when the fetus is born, even small excesses can lead to abnormal deposition of fat. So these are some of the theories that were put forth, but is there proof that it actually results in cardiovascular diseases? So there are more than 100 publications across the world. I mean, this is counting, this figure was around 5-6 years back. Now it must be 200 publications. So low birth weight kids have rebound adiposity, have high risk for hypertension, coronary artery disease, stroke, type 2 diabetes, and insulin resistance. In addition, these kids, when they grow, this is an example from a study that we conducted in India, the data from the New Delhi birth cohort. There are two lines here, the green line and the red line. The red line indicates those kids who went on to develop diabetes as young adults. This is a follow-up of a birth cohort, 8,000 children who were born. 2,000 of them were followed up in 1995 when they were around 24, 25 years old. And you can see some of them went on to develop diabetes. Some of them had the best glucose profile possible, which is in the green. So when you look at the red line, they start off with low birth weight. The birth weight decreases by 2 years and it starts increasing. When you have a good glucose profile, the birth weight, they have a higher birth weight. The weight increases at 2 years, but it starts declining. What is being suggested here is the weight, people who are born with low birth weight acquire a higher body weight as they are young children or young adults. And that is closely related to the occurrence of diabetes. They're not really obese. They have a higher body weight as compared to the cohort mean. So we said those who went on to develop diabetes became obese relative to themselves. So this is one aspect, that low birth weight increases the risk, and childhood, let's say higher BMI, or I won't call it as childhood obesity, higher BMI during children increases the risk of diabetes. But the most important point that we have to understand is there are epigenetic changes. The DNA undergoes changes if the kids are undernourished in the first 1,000 days. By first 1,000 days, we mean from the time of conception till 2 years of age. If the nutrition is inadequate, these kids have epigenetic modifications, the DNA gets methylated, and that results in several alterations. In fact, it is said a short mother has a higher chance of her fetus having a methylation in the oocytes in the ovary, which means that the next generation is already affected even before the child is born, because that the girl child in the womb will become a short mother, and ultimately we get another short child, creating this cycle of a social problem getting transmitted across generations. So if I have to summarize this framework of early life influences, low birth weight results in undernutrition and stunting, which results in physical effects and cognitive impairment. And I don't have to tell people from this institute, because cognitive impairment, even subtle cognitive impairment, reduces the chances of having a good job as they grow older. Socioeconomic consequences result in acquiring risk factors earlier and then developing cardiovascular diseases. So it ultimately leads to low productivity, social deprivation, and excess cardiovascular risk factors. By contrast, as we have developed, as young women have put on weight, and during their pregnancy, they are prone to develop gestational diabetes. So these mothers have children with high birth weight, and also in addition, poor nutrition results in childhood obesity, and that again continues with excess cardiovascular risk factors. But the most painful thing and the most important thing is stunted mothers have what is called as maternal constraint. And as I said, they beget smaller girl child. When they grow up, they also have the same problem. So there is a transgenerational effect of a social problem, which can be altered by interventions. Ultimately, we all know that excess cardiovascular risk factors results in high chronic disease morbidity and mortality. So the solutions to many of you is obvious. The obvious solutions are improve maternal nutrition, improve micronutrient intake of mothers, improve nutrition of the fetus and up to 2 years of life. There are midday school programs, there are feeding programs for children across the world, and all of them do help. Balanced diet during childhood. And people talk about health promotion to prevent childhood obesity and prevention across the lifespan. Now the question is, are these adequate? Can we reach all of them? How do you make this participatory? And there is another school of thought, okay, we do all this, but you want to prevent adult onset risk factors, you have to do health promotion, you have to educate people. This is what a lot of people say, you have to educate people to tell them this is good, this is bad, and the belief is that it will work. Now the question is, behavior change is not that simple. It's not that you give information to people and all of us have knowledge. I like sweets, but I'm a cardiologist and I know the harmful effects, but I have to have it. So it doesn't make a big difference in that information. So essentially what is needed is three things. You have to provide the knowledge to people so that they say, I know. You have to motivate them to say that, so that they say, I want. And you have to provide them with the skills to stop smoking or to prevent experimentation from smoking so that they say, I can. But most importantly, what is required is enabling an enabling environment. Some of the enabling environment is like, for example, sale of cigarettes or sale of alcohol to minors. You make it extremely difficult. You make it costly for young people to buy cigarettes. Or we talk about physical activity as an important tool. But in India or in many of the South Asian countries. Can people walk on the sidewalks? Where are the sidewalks? If they're there, what has happened to them? It's taken away by hawkers or people who park their cars. So how do we actually get those sidewalks to the people to walk? So that is an enabling environment. So you require to do all this to change behavior. But more importantly, what we have been doing so far, the innovation here is what we have been doing so far is targeting individuals, telling them that you have to change. The question is, can we target families or communities? So that it forms, that milieu actually brings up a change in their attitude towards healthy lifestyle. So we did a trial in Kerala to look at the efficacy of family-based cardiovascular risk reduction in individuals with a history of premature coronary artery disease. So it was a randomized controlled trial. And so there was a group of people who were given a family level intervention and provided support by a community health worker. The others got usual care. And we saw that the control of risk factors, this is people who had a heart attack, control of risk factors in those family members who did not have any heart disease was 3 times better than the usual care. So I think there is some story there that we have to target families and we have to target the communities. We also need to think innovatively, think beyond what we are doing. This is a study from Mongolia. I'm sure, this came as a surprise. The study was conducted in Ulaanbaatar, which is the capital of Mongolia. We all know that air pollution actually causes subtle reduction in cognition. And we all know what that subtle reduction in cognition does to schooling. It reduces your schooling by a year or so. And that reduced schooling can result in increased risk for cardiovascular disease, which it's a well-known fact. Michael Mormont here actually has demonstrated that very elegantly. Now, can we do an intervention? So they used a low-cost air purifier amongst middle-class mothers in Mongolia, and they did a randomized trial. So the others did not get air purifier. These people got a air purifier. At baseline, all were similar. And at 5 years, they assessed the cognition in these children. And they found that the IQ of the kids who had got the air purifiers when they were in the fetal life had an IQ of 3 points higher than the other kids. So you need to think innovatively in terms of addressing some of these issues. So I spoke about understanding the mechanisms and why it's important in diabetes. But let me move on and say, look at the role of artificial intelligence and machine learning in linking air pollution to cardiovascular disease. And I'm going to use hypertension as an exemplar here. So as you know, air pollution and cardiovascular disease are interlinked, and air pollution increases the risk for cardiovascular disease. A lot of people do not know that. When you ask people, they say, oh, it increases asthma, it increases lung infections, it increases childhood asthma and so on. But a lot of people are not aware that the actual effect of air pollution is an increased risk of cardiovascular diseases. So how does this happen? The air pollution is measured by what is called as particulate matter, and they're very, very small in size. They're 2.5 micrometers in size. It's 1/40th of, if you take a hair follicle and make small strands, it's 1/40th of that hair follicle strand. And that gets into, when you breathe, it gets into the lungs, crosses the alveolus, enters the blood. And when it enters the blood, it causes stiffening of the arteries that supply blood to various parts of the body. And that stiffening can result in hypertension. It can cause a direct damage to the heart, which can result in irregularities of the heartbeat. And it can cause inflammation and also cause what is called as endocrine disruption, resulting in several of the cardiovascular diseases. The problem is that most of the studies have come from high-income countries where the levels of PM2.5 is extremely low. What would you think would be the PM2.5, average PM2.5 in Glasgow in a year? Any guesses? It should be around 5 or 6, less than 10, because the recommendation by WHO earlier was 10, average should be 10, but now they made it 5, and I'm sure Glasgow will be 3, 4, 5, something like that. What do you think would be Delhi, the average in Delhi? Just a wild guess. Sorry? Average is not 400. It can go up to 400 on certain days. The average is around 125, 100 to 125. So that's the amount of air pollution that we have. The second problem is air pollution assessment, exposure assessment, as we call, happens at a coarser level. So what do you require for measuring air pollution? You require a monitor. So you put a monitor in the center of Glasgow, and you think that that will measure the whole of Glasgow. It does not, because as you move away from the monitor, the values change. Particularly in a country like in a city like Delhi, where there is so much of socioeconomic difference, that actually changes. So you require a finer resolution. So that's the second problem. The third problem is there is very sparse data from countries like India, which link cardiovascular disease to air pollution, and many of them are cross-sectional, and you understand the limitations of cross-sectional studies. So we used a longitudinal cohort that we assembled in the year 2009, and I've been following them up ever since. So every alternate year, we actually collect a full complement of blood samples, salivary, urine samples, so on and so forth. And we have followed up close to 20,000, 19,000 individuals for up to 8 years. And this study is being conducted in Delhi and Chennai. And this is a carefully phenotyped and geocoded population. And we have bloods in long-term storage to the tune of around 360,000 of this. And we have been recently funded to look at what is called as precision medicine, precision cars, in terms of identifying early markers of atherosclerosis. But this gave us an opportunity to study air pollution. And again, we were funded by NIH in a program called Geo-Health. So the idea was to create a robust exposure assessment of PM 2.5 at fine resolution and link this exposure to cardiovascular risk factors and outcomes and build capacity in the science of air pollution. So our main objective was to link PM 2.5 levels to incident cardiovascular risk factors and outcomes in Delhi and Chennai. Here is the map of Delhi. So we created a 1 kilometer to 1 kilometer grid of that map. And so we had close to, I think, 1,600 grids in Delhi. And we obtained the data of PM 2.5 for every day from 2010 to 2016. So it was a total of 7 years and 2,500 days. We got the value of PM 2.5. Now, how did we get the value of PM 2.5? We use multiple sources. First is we use monitors. There are 25 monitoring stations in Delhi. So we obtained data from them, and we obtained the data of PM10 and PM 2.5. Now, PM10 is a larger particle, and you can model the data of PM10 to get PM 2.5. A satellite goes around every country, actually, and you can obtain the data of that from the satellite. We get what is called as aerosol optical depth. The satellite also produces, gives you several other information which you require to adjust to get your PM 2.5, such as vegetation, ultraviolet emissions, and active fires. Then you have these polluting industries, and each polluting industry is mandated to have an emission inventory. And so we obtain data from them, particularly from brick kilns in and around Delhi. People who visited Delhi to Agra will find a lot of these brick kilns around Delhi. Then you need to adjust for several factors. It rains every day in Glasgow, and actually the PM 2.5 can get washed away by the rain. So you need to get what the level of humidity, what the level of rain, what the level of wind speed is, so on and so forth. Then you also need to look at land use. How much greenery is there? How much green cover is there? What's the role of parks? How far away are these people living from the roads, which are highways or very close to high traffic network, and so on. So we put all this information, use a machine learning model called ensemble modeling. Don't ask me what exactly it is, because I can't explain that, but it's a machine learning model. And we use a chemical transport model and adjust for the meteorological variables and get the value of PM 2.5. Here is a representation of what happened between 2010 to 2016. So closer to the red color, very high levels of air pollution. Closer to the green color, the optimal level of pollutants in the air. And as you can see, when you look at 2010, the red color starts appearing in the month of November, December, and January. But when you look at 2016, it actually starts appearing in October and goes close to March. So this is a good example of how air pollution has increased in the city of Delhi within a matter of 6-7 years. Then you also looked at walkability index in Delhi. Several factors needs to be put into this walkability, and you look at this last panel on which is walkability. The green points are very, very limited there, which means that there is the walkability index in New Delhi is poor. So these are innovative policy relevant research using machine learning models to show the government where they can intervene. And finally, when you look at this, you can see that these larger dots represent people with higher blood pressure, and you see where they are living. They are living very close to roads which have very high traffic. They are living close to the highways. People living in the periphery where the road network is not so congested, they have a lower level of blood pressure. So indicating that there is a big relationship between what happens in the environment and blood pressure. So we estimated and we linked the air pollution to incident hypertension, because we had this cohort study. The blood pressure was measured 3 to 4 times. And so we knew who was becoming hypertensive at a given point of time. And so we linked them to the level of PM 2.5 from their vantage point to like for example, their houses, to the closest monitor, and estimated the PM 2.5 for them and linked it to them at 1 week, 1 month, 6 months, and 1 year and 2 years, and found across these durations, whether it is short term, medium term, or long term, blood pressure levels were higher depending on the PM 2.5 levels. We estimated for every 25 microgram per cubic meter of PM 2.5, the blood pressure increased by 3.5 to 5 millimeters depending on BMI. Now you might say, how does it matter actually? If my blood pressure is 115 and because of pollution it's gone up to 118, I'm still not a hypertensive. But at a population level, it makes a big difference. So we can see this from this picture. We can see how it changes. This is an old study which was reported almost 30 years back. It's a model data which says that if you reduce the blood pressure by 2 millimeters in the population, you can reduce stroke-related mortality by 6%, overall mortality by 3%, and coronary artery disease mortality by 4%. And that's the power of population-based interventions. Now we are talking about 5 millimeter in Delhi for every 25 micrometer. So you can see that you can reduce stroke by 14%, coronary artery disease by 9%, and overall mortality by 7%. So we also have linked, established with other diseases, and we are in the process of publishing these: diabetes, heart failure, stroke, etc. Now we have shown that air pollution is linked to several cardiovascular diseases. That's a fact now. The question is, we know that, but we need to do something. And what are we doing? We need to demonstrate that we can do, at least till the government changes its policy and across the board tries and reduce air pollution, for those patients with severe disease who can die when there is a PM 2.5 level of, as you were saying, 400, it can even go up to 1,000. And those days, these patients can have a arrhythmia and die. So we are doing a randomized trial in heart failure in 3 centers. It just yet to begin, but it will start soon, where we're using HEPA filters, which filters out PM 2.5, and we are comparing it with sham filters, which are bacterial filters, and looking at major adverse cardiovascular event at 3 years, because heart failure mortality is almost 50% at 3 years. So even if you are going to reduce it by 20-25% by this low-cost filters, we would have made a big change. So that's one of the innovations that is being looked at. So this is about a high-level intervention, but what do you do at the level of health systems? What do you do to patients? So that's the focus of my next talk. So when we talk about cardiovascular disease prevention, there are 2 paradigms. People have always been talking about this. One is population-based, and the second is a high-risk approach. So Jeffrey Rose said sick individuals arise from sick population. That he said you have to make the sick population into a healthy population, and you focus on the population. But there are others who say no, it's the effect is not going to be very high. It's going to have small effects. So it's better to treat these individuals who are at the highest risk, because when you treat people at the highest risk, you get the maximal benefit. But the fact is you require both, because the population-based approach addresses the bulk of the distribution through small shifts, and the high risk addresses the individuals at the highest absolute risk of cardiovascular event. So the population-based will have large benefits, but with small changes, like we showed the 2 millimeter reduction in blood pressure. But the high risk will have high impact and is the cost-effective use of resources. So to look at this, we looked at 2 things. One, we have a huge shortage of doctors and nurses in India. So question is whether we could use community health workers. And second, we looked at low-cost solutions in terms of technology, such as using point of care devices or providing them with an electronic decision support system, by which I mean, let us say that a patient walks into a clinic, has a blood pressure of 160 by 100, no diabetes, non-smoker, BMI is 22, everything is all right. So the machine actually in the back end calculates and says, okay, this patient has got only hypertension, no other risk factors. So advise him or her to continue the lifestyle that they are following. But in addition, will require amlodipine 2.5 milligram. So it actually helps the doctors in terms of focusing on other things rather than, these are routine things that can be done. And so we did several trials. And some of the principles that we used is integrated care, because in many health systems, they're working in silos. Somebody manages hypertension, somebody manages diabetes. So can one person at a lower level of healthcare, empowered with an electronic decision support system, can manage many of these diseases? It had quality improvement program. We also had trials of cardiac rehabilitation. Instead of using the conventional cardiac rehabilitation, which is very expensive, we use yoga. It's one of the largest studies published a few years back in the Journal of American College of Cardiology, in which we showed quality of life is vastly different in people who use yoga care as compared to usual care. Then we looked at team-based care and some management principles. So question is, what are the technologies that are available for cardiovascular disease prevention and management, and how do we harness them for hypertension control? So in terms of technological solutions, we can think of 4 aspects. Number 1 is surveillance, where now we have started using biomedical sensors in our Google watches, Apple watches, and so on, which actually gives you the blood pressure, gives you your sleep pattern, gives you your oxygen saturation, and so on. And you can collect that data. And in fact, it has been published recently of millions of people. So that's can be used for surveillance. Second, that can be used in terms of screening or diagnosis is to use simple point of care device. The simplest example is your blood sugar measuring glucometer. So similar to that, you can have several of these point of care devices. Then you look at computerized assessment. The third is in terms of management. I spoke about the electronic decision support systems and pharmaceutical innovations. I'm going to talk about the polypill a little later, and telehealth. And there are several others that include various technologies that are being used now, like geographical information systems, digital teaching tools, digital clinical trials, and so on. But in terms of digital health, what is our aim? For the patients, we wanted them to have the greatest satisfaction, better access, improved treatment adherence, and a personalized care. For the provider, we wanted to provide them with a decision support system, an electronic patient information record, and we also wanted them to save time and focus on the art of medicine. And for the health system, we wanted improved quality of care, and also we wanted to generate big data for mining and for artificial intelligence. So what's the process that we followed? We did these trials in multiple settings, from community to primary care to secondary care. We used multiple methods that included formative research, randomized controlled trials, cluster randomized trials, demonstration projects, and so on. We have had several high impact publications, and we have done several state level and national level scale up, and we created a sustainable program, and we are foraying into new areas that includes maternal and child health, mental health, and so on. So this is the journey of the projects that we have done on the role of electronic decision support system. We started with the tertiary care because we want to demonstrate this, that it works in a gold standard setting. Then we moved on to community primary care. Then we scaled it up in 2 states of India, but now we are evaluating it for a national level scale up. And we have helped the WHO in terms of digitizing its pen package, and that's being used in Maldives. Just to give you an example, the decision support system recommends a certain treatment plan for a patient. Now, we looked at what happens if the doctor accepts or doesn't accept this. If the doctor accepts all the recommendations, you can look at the HbA1c control. For a doctor who did not accept, his or her patient had an average HbA1c at the end of the study to be around 8.6. But you look at, they started at 8.6, but it went down to something like 7.8. For the person who accepted all the recommendations, the HbA1c starting from 8.1 came down to 7.6. Similar is the case for blood pressure. Similar is the case for LDL cholesterol. So clearly suggesting that there are some errors of omissions, errors of commission by the treating physicians. So the impact of all of this has been standardization of care across all health facilities, task sharing with greater involvement of nurses in NCD care and delivery, reduced workload for medical officers, adequate opportunity for patients to explain their illness components to a nurse, better control of hypertension and diabetes, improved quality of care, and a powerful information system for the NCD program to generate data for informed policy planning. So it has, we can monitor health outcomes and we can actually change policy because we are getting real-time information at the level of the health facility as well as the state overall. So it has a potential to redesign health systems, but there are certain limitations. One is we are not integrated because all the work that has been done is at a government facility level. In India and in many parts of the world, we have both, unlike the UK, you have both the government as the private healthcare facilities. We need integration. So there's been limited private sector involvement, insufficient continuum of care models because this was all focused on the health system. A continuum of care model actually starts at the community and ends back into the community if we have to rehabilitate patients. So we need to look at that. There are inadequate referral pathways, thresholds and linkages, and need for management advisories for different levels of healthcare institutions. Like the primary care will have a differing requirement as compared to a tertiary care. And so we the experiments that we have done is a kind of one-stop solution. So you're required to disaggregate that and see how it can be done. The question is how to redesign the health system. This is a pilot experiment that we are doing in the state of Punjab, which is to the north of India, where we are trying to integrate all levels of care, establishing referral linkages, and also having a patient-facing app. So the patient is part of the solution. And this is an ongoing study which will get completed next year, and we'll know what happens to the results later on. Now, the COVID pandemic has actually resulted in several innovations. Like, for example, today we are having a hybrid talk. Some of you are here, some of them are on Zoom. Similarly, we can do that with chronic disease care because not every patient needs to come back to the hospital after the first diagnosis. They could just continue the treatment. And so telemedicine is a solution, but the big problem with telemedicine is the patients have to access the telemedicine portal, and many of them are not literate and also not digitally literate, even if they're educated. Doctors are also frustrated because they come into the wrong specialty. So we created a program which is an assisted telemedicine program, but the platform has several innovations. It has an electronic health record. It has point of care diagnosis. It has an electronic decision support system. It has a AI-based ECG solution. It has an electronic step. It has a high definition camera. And the most important thing is it's interoperable. So by interoperable, I mean some of you have an iPhone, some of you have a Google phone, some of you have Android. These phones don't talk to each other, and the softwares are very different. Now, how do we standardize all of these which come from different softwares and make them talk to each other? And that's the software that we have created. And so you can see here, you can actually deliver tertiary level teleconsultations at the clinics as well as at the homes. This lady is carrying all the telemedicine tools that I've mentioned here in these two small bags, and she's delivering telemedicine assistance in a house where the person couldn't come to the clinic. So you have those kind of innovations that we can do. I'm just showing you this portal, which is the software that we have developed. So the doctor can have the general physical examination findings. I think you need to press, yeah. Then a template-based history, like what a medical student or an intern would take. So it gets all that history. It's there in the back end. Lab results are given in a longitudinal fashion. ECG readings are immediately reported to the doctor. Then there's electronic clinical decision support system and e-prescription, as well as mark for follow-up and markup for referrals. And finally, somebody sitting in Glasgow can hear the cardiac sound of somebody in Chennai. So a doctor can hear and can follow the patient actually. So this is the power of telemedicine. Next one. So the impact in 1 year has been that more than 30% of the elderly population have been treated, 62% of are females. The cost is little high because right now it is in an experimental stage, but on scale, it will become to 25% of what the cost now is. And the satisfaction amongst the patients has been very high. So this is at the level of the health system that we have all these electronic decision support system. The last problem is the last mile connectivity. You prescribe medicines to patients, they don't take it. They say, actually, my father-in-law would say, I'm taking medicines like food. Every chronic disease person takes around 10 to 14 medicines and they just don't take it after some time. And therefore, you require an innovative solution. And one of the solutions has been polypills or fixed dose combination. A polypill is a medication that is a drug product in pill form that combines multiple active pharmaceutical ingredients. It does not mean that we put 4 or 5 drugs in one capsule and give it to them, because there can be drug-drug interaction. You require sophisticated way of handling it. One of the polypill trials that we did had microcapsules which would deliver drugs at different parts of the gut. But this proposition came from Walden Law, who published a paper in 2003. And Richard Smith, my friend who was the editor of BMJ, wrote an article and had this picture on the cover of BMJ. So the whole medical profession was like the Lilliputians who were looking at Gulliver. They thought this is something very new. But it has evolved over a period of time. At the time when they started, it was a very attractive proposition because they said there can be comprehensive risk factor control, treatment of several risk factors simultaneously, regardless of the level and without screening for them. It was population-wide. You don't have to measure anything. Give this polypill for people above the age of 55 years because they are at high risk. It had high efficacy. They believed that it had high efficacy. It would prevent half the cardiovascular diseases and would reduce the number of deaths by 2 to 3 million. No screening or monitoring required. It was a cost-effective way of delivering healthcare. And basically, you didn't have to go and see the Dracula in the lab or go and get your blood pressure measured. So that was the proposition. Now, over 15 years, we have gathered this evidence. We recently published a meta-analysis in the Lancet and another meta-analysis in Progress in Cardiovascular Diseases, and showed that for primary prevention, there's almost a 58% reduction at 5 years in terms of using this polypill. But the big but is there is enormous amount of resistance from doctors, patients, the health system, and the pharmaceutical industry, because these are off-patent medicines. At manufacturing cost, it would be like 1 pence, and it doesn't give them profit. So there's enormous amount of resistance. So we need to get over this entrenched philosophies, and a lot of people argue, saying that you medicalize these people. You know, would you ask a person to stop smoking or give these drugs? Because obviously the vascular risk is reduced by giving this treatment, but you would ask the person to stop smoking. But I would say that do both. Social acceptance is poor by both patients and physicians. The health system readiness, particularly health person availability and competence, is again a bit of a problem. In terms of financial feasibility, how can you do it on a scale? In low-income country, it may not be possible, but as we move along, we can actually manufacture it even lower cost. It ensures equity, but the question is how many polypills are required. Each disease you may want to have a polypill for heart failure, for diabetes, for stroke, for heart attacks. So you need different polypills. And what diseases should be covered is not yet clear. How do you get it to the essential drugs list? Once it comes to the essential drugs list, the cost will come down further. And how do we get into the universal health coverage framework? So that's at that level of the patient. The last 2 points that I want to make is about community. How do we innovate at the level of the community, and how do we do it? So solving challenges facing communities is through collaboration with these communities. And the communities may include patients, caregivers, community leaders, civil society organizations, policymakers, and so on. I think we need a paradigm shift in our thinking in terms of research. So research has to be carried out with the community rather than for the community. So we'll have to work with them and co-design whatever we do. And this is, we are going to start working on this in a big project where we are going to engage with community stakeholders for multimorbidity, understand their lived experience, identify community champions, and develop patient networks to improve management and empower them. But for all of these, finally, you need to have good capacity at the primary care, be it the primary care physicians, and at the level of researchers, you require to create those public health leaders who would advocate for some of these programs. So in this direction, we have built programs in collaboration with, we can, no, that's okay. Here, it's the previous one. Okay. So we have created training programs on a standardized fashion, and we have trained close to 32,000 primary care physicians across India in terms of several diseases, and we have expanded it to several countries. But we have moved towards digital training programs, and we are using several innovations such as gamification, rewards, and case-based learning. And we are also extending this training program to patients. Actually, how can patients themselves be trained through these digital methods? And we are piloting that and looking at the benefits of doing that. But you need to create leaders, future leaders, who will carry on doing this work. And that's one of the area of where we are working in Public Health Foundation of India and the Center for Chronic Disease Control, where we created these leaders who would work in specific areas. And we also are the Fogati International Center, where we have trained these global leaders and who have become leaders in their area of work. Many of them have gone on to become professors and directors, develop their own institutions, so that you can multiply what you think and expand it across the world. So reducing gaps in the management of cardiovascular disease, I think requires, we need to address 4 fundamental questions of public health. One, we need to get scientific credibility, and this is what most of us are focused on. So we are doing biomedical and epidemiological research in terms of obtaining the strength, quality, and generalizability of the evidence. But we need to look at financial feasibility. Is it cost effective? Is it affordable? And for that, you require health economic research. And I would suggest that you read the Disease Control Priorities, Volume 3. It has all the details of how to do it. In terms of once you create these programs, they have to be sustainable and scalable. And that's called operational stability. And for that, you require health systems research. And lastly, is the community ready and receptive? And that's where you require the community-based programs. So you require social sciences research. For all of these, you need multidisciplinarity, disruptive innovations, and attention to policy and upstream determinants. So I would like to leave you with this quote, that you need to actually, instead of taking the path that is well trodden, try and take a little different path to see whether you can address these challenges, but also to understand that science is reductionist. It has to be reductionist. You have to go down to the depth of science. But if you have to provide solutions, it has to be the breadth. And that's and that comes from a holistic thinking. So finally, I would thank all my collaborators in French, that is merci, but would plead mercy from all of those who have been left out in that by mistake. And I also would like to thank my family for allowing me to do all this, and my extended family, because of whom we have got all these wonderful studies. So thank you very much for listening to me so patiently.
Excellent. Really comprehensive talk on where things are at the moment and some ideas for the future. Any questions? I'm sure there are probably quite a few. Go ahead, David.
So who are clinicians who did not like our recommendations? It's generally the specialists, because they felt that we were dumbing down the evidence. They said that we know. And the other problem was patients did not like, because these were simple drugs. Like, for example, if you're going to prescribe enalapril, which is just in Indian cost, it would be 50 paise or 5 pence, maybe. Instead of that, no, 0.5 pence, I think. Yeah, 0.5 pence. So instead of that, they would want something which is new, like candesartan, which would be 32 rupees, which would be 30 pence. So that's the kind of problems that people face. The second reason why there was a rejection of the recommendation is non-availability of the drugs in the system. So these are the two main reasons. Zoom, they can write in the chat box, I think, right?
I think so, yes. I think, Desmond, did you put your hand up on Zoom? Did you want to ask a question or type it in?
Yeah, I did. It's just a question about the polypill or that sort of idea. You could say by exposing yourself to multiple drugs, you have more exposure to chances of a severe side effect, or the alternative is, you're giving multiple drugs and therefore a reduced dose of each drug, to compensate for multiple drugs, and therefore you've less chance of a side effect. And I wonder which way around it is, or if it's not clear.
We have learned over the last 15 years several of these aspects. Number one, the paradigm of management of hypertension has changed with recommendations for giving either half doses of 2 drugs or quarter doses of 4 drugs, because these drugs act in a very synergistic fashion. Earlier, the management of hypertension used to be start with 1 drug, go to the maximal dose, then change it over to another drug if it's not controlled. But with the current concept, reducing it to the lowest level and also having the benefit of synergism, it's beneficial. Yes, you're right that one of the problems is in polypill is you stop it, suddenly you're stopping all the drugs. Unlike in the past when you're giving multiple drugs, people would stop 1 drug if they felt that was causing them a problem. But in the randomized trial that has been conducted in Iran, the benefit was huge. I mean, the risk-benefit ratio is very highly in favor of benefits, despite the problems that you have suggested. It does occur. I think Dr. Dominic Jack has a question. You're muted.
Go ahead, Professor.
Yeah. Go ahead. Thank you very much. Thank you for a great lecture. It covered entire cardiovascular areas. Thank you very much. I wanted to ask more about polypill. You showed beautifully why there is such, years of rejection, not wanting it. Now, with all the evidence for multiple trials and fantastic publications, New England, Lancet, do you see internationally that people start accepting? When I look at international guidelines, some of which I contributed to, European guidelines, for example, there is still very little about polypill there, not even put forward as an option. What do you think we need to do to change it?
It's an easy question as well as a very difficult question. Easy in the sense because the evidence is very, very glaring at us, showing that it's hugely beneficial. But the arguments that you'll have is people will say, "Oh, we have not done trials in Europe. We have not done trials in the United States. Until you do that, we cannot give." Unfortunately, most of the trials that have been done, although trials of polypill have been done in UK in the realm of secondary prevention, but in terms of primary prevention, most of the trials have been in India, Malaysia, Europe, Colombia, Spain, and Argentina. So there is hardly any study from the high-income countries, and therefore they might demand that. So one of the things that we need to do is we don't really require, now that we have shown in countries like Iran and India that we have shown there is benefits in terms of MACE. I think the studies that are required in Europe and US should be short-term studies looking at process outcomes or small changes in blood pressure or in blood sugar. That's the kind of studies that is required. The second thing is in the second generation polypill trials, we should look at polypill trial for heart failure, for example, because heart failure is a different beast. We have multiple other drugs. And in fact, one of my colleagues is actually going to work. She's got a study funded to work in India, and it's recently been approved where we are looking at a polypill for heart failure. So we just started the pilot. So as we gather more and more evidence, I think there will be an uptake. But in addition to that, I think there's a lot of advocacy that is required, a lot of advocacy from leaders like you in terms of getting. So Salim Yusuf recently organized a meeting in the World Heart Federation and created a consortium of interested people in terms of getting this message across. But it's an arduous journey, and we will have to wait and see.
Thank you.
Thank you.
Okay. Any more questions in the room?
I think Dr. Kate O'Donnell is asking a question.
Okay, go ahead, Kate.
Thanks. Thank you for a wonderful presentation. There was so much there that we could learn from, and I'm only sorry I wasn't able to actually be there in the room today. I wanted to ask about the digital health interventions that you are developing. There's a lot there, I think, that we can learn about the implementation of those. How do you start to ensure that those are implemented and are sustained in health systems after the actual initial work and the studies of the trials are completed? Because that's often where digital interventions peter out.
I think what is required is a government support. And luckily in India, the government is more tuned towards introducing digital health. In fact, there's a digital health mission which has been constituted recently, and they have a program for digital consultations, which is somewhat primitive. It's not as sophisticated as what we have, but when you work in consultation with them, it will improve. So without the government support, without the support of large private healthcare institutions, managed care institutions, insurance, it will not work. So we will have to engage with all of these partners. Otherwise, it will peter out. You're very, very right that it will be very exciting. If this is not taken up, it will not work. So government support is very crucial. But at the same time, organizations like the World Bank, for example, organizes Disease Control Priorities Project. And some of them, they're doing some pilots in Pakistan and Rwanda on digital health. So I think there is hope.
Thank you.
Any more questions, either online or in the room? I'm just going to take the chair's prerogative of asking you a slightly left field question. So many of the issues and key barriers you've raised arguably relate to the commercial determinants of health. And so some of the challenges with addressing air pollution are probably quite comparable to some of the challenges with getting the poly pill taken up. I was wondering if you had any thoughts about how to actually achieve that kind of advocacy you were mentioning.
So I'll give you the example of UK, how it handled one of the commercial determinants of health on processed foods. 15, 20 years or 30 years back, the salt content of bread in UK was very high. So the government had a consultation with the industry and said, look, if you're not going to regulate yourself, we will regulate you. So the industry heard that. They got the Riot Act ingrained into them. So over a 10-year period, they said, give us 10 years and we'll reduce salt content in the bread by 50%. And because when you make small changes, people don't perceive it. So they did small changes, but in an incremental fashion over 10 years. And that's yielded enormous results in terms of reduction in cardiovascular diseases. I think the most important thing is non-personal policy intervention, where people don't really perceive that change, but at the same time, regulating the market forces to cater to the new demands. And so you also need to create, along with reducing that supply, you need to create that demand. And the demand creation is that behavior change communication that I mentioned. Where the three components are I know, I can, I want, and the enabling environment. So you need to do all of those.
Excellent.
Yeah.
Okay, so really excellent.
Thank you. Thanks to the online friends there.